Hello, everyone. Welcome to our Cat Project Echo. It's good to see you today. Um, just as everyone's coming in, go ahead and drop your name, your county, your clinic into the chat so everyone knows who's here. And I know that we're coming in the middle of really busy days and carrying a lot. And so I'd also like to welcome us just to take a couple of really deep breaths. Just a little moment of silence as we're welcoming everyone to come in. And if you want to also add into the chat as a grounding, what is one thing that you're grateful for today? Yeah. Hope it's not to be taken for granted. So welcome everyone as you're coming in. Go ahead and drop your name, your organization, your county into the chat. And what's one thing that you're grateful for today? I think most people know who I am. I'm Joanne Jung. I'm a general pediatrician here at UCSF, helping to organize these activities. I am really grateful for my community, the people who help to hold and support me through all the ups and all the downs, and can't just do everything that I do without them. So grateful for my community and my family. Give others as well coming in just a couple more minutes to share name, organization, and just where you're from, one thing that you're grateful for today. Great, as people are doing this, let's go ahead and move on to the next slide. Couple announcements for today. We had to do a bit of a pivot today. So we had originally been planning to talk about gender dysphoria, and unfortunately, our speaker wasn't able to join us kind of at the last minute. So we'll be pivoting today and talking about sleep, which is another very important topic. And if you happen to have a patient who's really struggling with sleep issues and you'd love to have the group all talk about it together, please feel free to volunteer like after our talk is over to share some of the details about your case. Just asking to leave out any PHI so that we keep this all HIPAA compliant. We will be recording the didactic portion of our time together just for posting on our website later. But especially as we go into the case discussion, it'd be great if you could turn your cameras on so that we can see each other as we're having our conversation, especially as we're discussing the case. And we do have one more session coming up in June, and that's going to be on adolescent substance use. So if you've got a patient who's got substance use issues and you've got questions about the diagnosis or the management, please let me know, and we can see about having you share your case in June. Finally, I do also want to remind everyone that our call line is another resource and a great way just to apply all these concepts that we're learning in ECHO for your specific patient needs. Great way of building up confidence and skills. And so just a reminder of our consultation line, the number's right there. You can talk with either psychiatrist or you can actually talk with a psychologist also for their unique insights about patient psychoeducation and treatment possibilities, etc. And so with that, let's go. I'd like to introduce our speaker. I think most of you know Lauren, but Lauren Schumacher is a child and adolescent psychiatrist here at UCSF in our Benioff Children's Hospitals on both sides of the Bay, providing clinical care in the outpatient clinics in San Francisco, as well as in Oakland. She completed her bachelor's degree at Harvard Medical School and adult psychiatric residency at Northwestern, and her child and adolescent psychiatry fellowship here at UCSF. She'll be speaking with us on sleep. With that, I'll hand the virtual mic over to Lauren.
Thank you for that introduction, and thank you guys for being here today. I know that this wasn't the topic you were expecting, but we appreciate you flexing with us to talk about sleep. Briefly, in terms of disclosures, no one involved in the planning or presentation has any relevant financial relationships to disclose. But CAP is supported by federal and state grant funding, including a HRSA grant, and also Prop 56 Behavioral Health Integration Funding. So the objectives for the talk today are to explain how to conceptualize sleep difficulties in children, describe how to behaviorally approach sleep problems, and also explain some of the guidelines for medication use as an adjunct in children with sleep difficulties. So in terms of what we're talking about, we expect, all children are going to have sleep challenges sometimes, but pediatric insomnia is really getting at something that is more frequent and persistent and causing functional impairments. So you're looking that it's kind of happening at least 3 nights a week for greater than 3 months. With that, you're seeing either issues with sleep onset, wakenings at night, or early morning wakenings, or more than one of those, and that those are not kind of, not age-appropriate difficulties. So obviously, if an infant is waking in the night, that's appropriate and not something we're talking about here. And that they're having these difficulties despite kind of age-appropriate time and opportunity for sleep, which also can be a major factor for a lot of our patients, especially teens. And then that it's resulting in functional impairment for either the child and or the family. So those are the things to keep in mind. A helpful screening tool to use to kind of be screening for sleep problems called the BEARS. This is what the tool looks like. And it'll be included in the handout that we will send you and is also on our website. But it's looking kind of, the BEARS is an acronym for B for bedtime problems. So there are issues with kind of sleep arrangements, falling asleep, issues with routines. E, excessive daytime sleepiness. Are they napping in a manner that's not age appropriate? Are they having a lot of fatigue, needing a lot of caffeine? A, awakenings at night. Are they waking up at night? What happens when they do particular triggers like night terrors, seizures, enuresis? Kind of what's the regularity and duration and pattern of sleep? And sleep diaries can be really helpful to get into more details. And if there's any S's for snoring, any snoring, kind of screening for sleep-related breathing problems. And, unfortunately, sleep problems are pretty common in the pediatric population. It's estimated that kind of 20 to 30% of preschool age and younger children have sleep difficulties. Part of that it's helpful to keep in mind, and I think often helpful to talk with parents about too, is that sleep is a skill. It's a developmental process. And, we can think about with infants, that's really broken up sleep. There's not really much regularity scheduled to it. And then as they get older, they gradually kind of consolidate sleep, kind of learn skills for how to make that big transition from wakefulness to sleep and then awake again. And then with teens, it's also very common. And teens often, it's a lot of issues with inadequate sleep hours. So it's estimated that kind of 7 out of 10 high schoolers are not getting enough sleep, which I'm sure is not a surprise to most of you. And that I think there's a lot of different challenges between, demands of school, activities, and friends, and also often a mismatch of circadian rhythm shift where teens want to be up later and wake up later, but still then, so they'll stay up late, but then still have to get up early for school in the morning. And kind of in this context, it's also helpful to think about the kind of developmental, environmental, and cultural factors. So, in terms of environment, certainly that sleep schedules, the school schedule can have a big impact. Getting a sense of what their sleep environment's like. Often in the Bay Area, people have, um, you know, since the higher cost of living area, often people are, sharing rooms, and it can be help. Sometimes there's maybe an elementary school's kid that's staying up late, and then you find out, oh, he's got, his teenage brother is up on the computer in the room until late at night, or things like that, that can really have an impact. And then also cultural factors, certainly different families have different approaches to sleep. Co-sleeping is a big one that comes up, and thinking about kind of taking the family's kind of specific goals and cultural factors and how to help meet them where they're at. So by far the kind of most common sleep problem in children is behavioral insomnia of childhood. And with that, there's kind of two main groups. There's the sleep onset type. So they tend to have difficulty initiating sleep and have kind of demanding sleep onset conditions. So this is, the kid where it's there's just different sleep associations. So they have to be rocked or fed. They need the parental parents, presence, or may have to like be holding their parent to fall asleep. And it's often very labor intensive for the caregivers. There's some various risk factors for it. One is intrinsic, in terms of kids with a difficult temperament are more likely to have sleep onset type behavioral insomnia. And then also some intrinsic, some parenting style, attachment, co-sleeping, the sleep environment, parental anxiety can all contribute as well. And these we really think of as the maybe in some ways like maladaptive sleep associations. And often they're ones that at some point were age appropriate and adaptive, but then at some point they kind of stop working as well for the family. And then the limit setting type, you see more, it's kind of the child may delay bedtime onset with bed refusals, tantrums, can be trouble either initiating or maintaining. They may kind of go into the room, come out again, a lot of attention seeking behavior. And this one's more associated with kind of parental difficulties with limit setting, and that often there may be kind of inadvertently reinforcing some of these behaviors. And then kind of within sleep, another kind of group we really think about is autism spectrum disorder, and sleep problems are very common in those with ASD, with kind of about over 50% having sleep problems, but often both problems with initiating sleep and maintaining sleep. But it's helpful to keep in mind, while with ASD, kind of we do think there's likely kind of neurodevelopmental differences that are making it harder for them to sleep in some cases, that they're also very prone to behavioral insomnia of childhood. And it's still kind of helpful to really do behavioral strategies first, as well as kind of looking for if there's comorbid medical or medication causes that can be contributing to the insomnia. And then potentially thinking about low dose melatonin if kind of they haven't improved with behavioral strategies alone. And really there's limited evidence for treatment of sleep disorders in ASD, but the best evidence is for kind of melatonin plus CBT, potentially melatonin alone, and potentially kind of CBT alone. A common one that comes up, I think, is questions about weighted blankets. There's kind of some evidence that it's possibly not effective, and likely the risks are fairly low. So if it's something the family wants to try, it's reasonable. So then really with kind of sleep problems generally in pediatric populations, and specifically the behavioral insomnia, we know that the behavioral strategies are the most effective treatment, and that there's very limited evidence for any medications to help with sleep in kids and teens. So really emphasizing sleep strategies is helpful. So a lot of that often starts with the sleep hygiene and getting a sense of kind of what's working, what's not working for the family currently. Really encouraging having firm limits around bedtime and kind of a clear plan, having the same schedule every day a week and avoiding big shifts between weekdays and weekends. Checking in around that the bedtimes behave developmentally appropriate. So sometimes I feel like this comes up in the elementary age group that suddenly they're having, you know, a 7-year-old and the family is kind of used to them going to bed like 7:30, and suddenly they're in bed and they're not falling asleep. And sometimes family needs, okay, maybe it's time to shift that bedtime a little bit later. And then if they're kind of in a pattern of sleeping very late, it can be helpful to very gradually shift that sleep time earlier, while then shifting the wake time a little earlier or consistently, depending on how much sleep they're getting. And, you know, with the bedtime routine, really trying to limit it to 30 minutes, not having it be as, you know, too labor intensive, having it be manageable and something they family can do consistently, avoiding high stimulating activities like running around or TV or electronics, and thinking kind of maybe 2 to 3 calm, enjoyable activities like bed, you know, bath, bedtime stories, things like that. And then kind of really trying to put the child to bed awake, because if they get into the habit of kind of falling asleep while the parents there, and then that's going to kind of continue to feel like something they need to have there to be able to fall asleep. And there's kind of different approaches to use. I think you guys are all well versed in terms of either kind of taking more of a cry it out kind of approach versus a gradual extinction, where you're kind of gradually removing that caregiver presence for longer and longer periods to try to give the kid space to learn how to fall asleep without that support. And then kind of if it's older kid who's leaving the room, just kind of continue supporting the family and continuing to calmly and firmly bring them back to the room, not locking them in the room, and then keeping calm, because often the kid's getting upset and frustrated at this point, and it's really easy. Everyone's tired. It's the end of the day. Very easy for parents to get frustrated and upset too, but that can kind of escalate things and make it worse for everybody. So really, I think a lot of upfront guidance that it's, you know, there'll be an extinction burst, it will get worse, and it's really hard, and just kind of continuing to be calm and boring and just kind of matter-of-factly redirecting them back. And then on the flip side of it, when they are kind of able to have a successfully fall asleep on their own, really reinforcing and rewarding that. So acknowledging that with praise, thinking about things like sticker charts or having a favorite breakfast item to really reinforce that. And for the most part, just ignoring the negative behaviors. There's no need to kind of go back over those. And just encouraging the parents to be consistent and calm. And so kind of in terms of behavioral interventions, one of the ones that has best evidence is CBT-I, cognitive behavioral therapy for insomnia. Unfortunately, there are not that many providers that really focus on this, so often it can be very hard to find. But I think it's helpful to kind of look at the principles of it, because a lot of it is, you know, at least little pearls and pieces of it are things that can be conveyed even in short pediatric office visits. So there's 5 pillars to CBT-I. The first is sleep hygiene education, which I think is something a lot of you are already doing in your offices a lot, of kind of keeping naps short if they're napping, having a regular sleep schedule, having you know, optimized sleep environment, ideally quiet, dark, cool, really having no electronics or screens before bedtime or in bed, and then stimulus control, really encouraging people to just sleep in bed. And if they're awake in bed for more than 15 minutes, to actually go ahead and get up, do something boring for a while, and then try again. And that can be pretty counterintuitive sometimes, but can really help and really encourage if they're having problems like not reading in bed, no TV or phone in bed, not studying in bed. I feel like that's really common for our teenagers. And instead kind of trying, okay, maybe you have like a beanbag or like a comfy chair you sit in near your bed where you read some and then you go into bed when you're going to go to sleep. And then sleep restriction is the third pillar. So having kind of strict, specific sleep and wake times, and kind of gradually increasing time in bed when they're falling asleep more quickly. So if you've got a kid or teen who's like, okay, I'm getting in bed at 9:30, but I'm in bed lying there trying to fall asleep and not falling asleep until 11, it would be better to have them, okay, shift to just go to bed, between 10:45 and 11 and see that there should be falling asleep more quickly so that they're getting in bed later, but once they're in bed, fall asleep quickly, and then very gradually shift that time back. And then the fourth pillar is, relaxation techniques, things like deep breathing, meditation. And the fifth is cognitive therapy. So often they develop a lot of unhelpful thinking patterns, like catastrophizing about, okay, if I don't sleep, what's going to happen? I'm not going to be able to sleep, and then I'm going to, be really tired and fail my exam the next day. So that's kind of the fifth piece. And this is also something, so even if you're working with a patient who has a therapist they're working with, even if that therapist doesn't focus specifically on CBT-I, a lot of these skills are also something you can encourage the patient and family to talk with the therapist about as well. So then in terms of medications, I think it's helpful to keep in mind there's no medications that are FDA approved for pediatric insomnia. So it's all off-label, and unfortunately, there's very limited evidence for any of them. And they're really not a first-line treatment and shouldn't be used alone. So really start by emphasizing the behavioral strategies, but in cases where that's not enough, you can think about medication kind of in conjunction with ongoing behavioral strategies. But usually you want to have it be short-term to kind of help them get adjusted, because kind of once they stop the medication, often some of those issues come back. So really the long-term treatment is going to be those behavioral changes. And then with that, making sure to screen for any illicit drug use and also over-the-counter medication, and be kind of thinking about other sleep disorders, like if there's anything like sleep apnea going on as well. Probably the most common medication that comes up is melatonin. And there's kind of two different things that melatonin can do. In a very small doses, it has a chronobiologic effect where it helps with phase shifting. So that's kind of thinking things about like helping with jet lag if somebody has come back from a trip. And then at higher doses, it also has some hypnotic kind of sleep promoting effects as well. So it's helpful to first think about kind of what are we using the melatonin for? Is it more to help with kind of the phase shift, or more just that they're having, more that the hypnotic effect? If the hypnotic effect, you want to give it 30 to 60 minutes before bedtime, and a little bit higher doses, more in the 1 to 5 range, depending on the age. For the circadian phase delay, it's smaller doses, like the 0.5 milligrams, and actually much earlier in the day, so more like 5 hours prior to sleep onset. And then you want to start at low doses, like 0.5 to 1 milligram. And honestly, really, I know we have infants here, but I think we really would run a really focus on behavioral strategies and not use melatonin in infants. In kind of those with autism or other neurodevelopmental disorders, sometimes they actually end up needing significantly higher doses. So I'd still start low with them, but you may find yourselves up at more like 10 milligrams. Ultimately, if you're noticing kind of continued, maybe little to no benefit with 1, but then you go to 5 and you're like, okay, there's some benefit, but still room for improvement, you may end up going up to 10. I think with melatonin, some concerns are, while it seems to be safe short-term, we really don't know the long-term effects, and kind of long-term melatonin use has kind of been more and more common. So that's something to keep in mind. And interestingly, with melatonin, there's actually, the evidence is better for those with insomnia and comorbid autism or ADHD than kind of kids with insomnia without other comorbidities. And then in terms of other medications, we also sometimes think about antihistamines like diphenhydramine or hydroxyzine. And these can be used kind of primarily to help with sleep onset. Advantages are they're kind of relatively available. Often families are kind of familiar with kind of how they affect their kids from using them for other contexts. Downsides are they can have the anticholinergic effects. You can get daytime drowsiness. Some kids will have a paradoxical excitation. And the other thing is they don't work forever. So they will help, they'll make them pretty drowsy initially and help with sleep. But if they're taking it frequently, it will really stop helping with sleep. So again, it's kind of a short-term thing in conjunction with those behavioral strategies. And then another we sometimes think about are the alpha agonists, guanfacine and clonidine. Clonidine is to some extent hits kind of more of the different alpha-2 receptors and is thought to be a little bit more sedating. With both of these, I think we especially think about it in, they are FDA approved for treatment of ADHD. So we think about them especially in our kids with ADHD and sleep problems that they can kind of help with both. I think they're also one that we pretty commonly use in those with autism and sleep problems who also often maybe have ADHD as well, or at least some ADHD-like symptoms. With these ones, really kind of lower blood pressure, dizziness are things to keep an eye out for, rebound hypertension if they're on higher doses and abruptly discontinue it. And that they may have some more difficulties with sleep when they stop it. And sorry. One slide I'm missing here, but then the other one I wanted to mention was just there are some antidepressants that we sometimes use off-label to help with sleep, specifically trazodone and mirtazapine. With both of those, again, I think it's helpful to keep in mind that they're not FDA approved for treatment of sleep, and their FDA approval for treatment of depression is in adults. So it's an off-label use, but in teenagers, this is really not something we use in younger kids, but in teenagers, especially if they have comorbid depression, anxiety, or both, as well as sleep problems, they're one to think about. That being said, I still generally would go if it seems like the sleep is really potentially part of the depression picture, I would still go with an SSRI to treat the depression first. And then if there's, that seems to be helping with the depression, but there's maybe some lingering or particular sleep challenges, we might think about kind of adding on a little bit of trazodone or mirtazapine, or if they kind of don't have a good response with SSRIs, then thinking about trazodone or mirtazapine. But it's hard. There's really, we all have those kids that really struggle with sleep, despite having done a lot of behavioral work, and there's really not great evidence or guidance for medications at this point. So it's still something where, there's a trial and error aspect and kind of just consulting the family that we can try this, and there's not a lot of evidence for it. So some of the main take-home points for today is, with sleep problems, thinking about always thinking about what's contributing to it. So are there environmental factors that can be adjusted? Are there medications or other substances that are affecting sleep? Are there other medical causes like sleep apnea, seizures, thyroid problems that are affecting sleep? Really emphasizing sleep hygiene and behavioral management. Because for all of us, I think if we think of ourselves, there's always room for improvement in terms of sleep hygiene, especially now that we all have our little computers that we often take to bed with us, even though we know they're going to keep us up later. And And then thinking about if there's other comorbidities like ADHD, autism, depression that might be affecting sleep, treating those, and then considering augmentation with pharmacotherapy in conjunction with behavioral strategies if that's not working alone. All right, and then here's some online sleep resources that will also, or you can review in the handout as well, but there are some online CBT-I kind of programs and apps that can be helpful in cases where you feel like you've got a, especially a family or team that are pretty motivated to work on sleep, but aren't able to get in with someone. These can be really helpful resources that kind of walk through the different CBT-I strategies.
Wonderful. Thank you so much for that great presentation.